Good morning, everyone. I'll present now on the foundation models for medicine, and I will start from our first work in this domain, which was published the preprint was published mainly in 2019. So it was just directly after the release of the BERT model. So I'll talk about Med-BERT and what we are working on expanding that in order to have foundation models. So I will just first describe what is foundation models to make sure that we all understand that. And second, I'll talk about more on the clinical side of foundation models and then on Med-BERT and the new version of it and some use cases and some future work. So just like previously, what is foundation models? They are like AI models, mostly deep learning models trained on large data sets in order to, is trained to mask one part of the input and try to predict that. That is what we call self-supervised. So the input is there, they have the full input, randomly mask one part of it and just learn it. And then this model, which we learn, it learns some sort of representations or what we call embeddings that we can further use that and fine tune them for task-specific on task-specific data to get a more specialized model. So that is the idea of foundation models. So when we are talking about clinical foundation models, that means that is mainly trained for the use with clinicians and for the healthcare purposes and the biomedicine purpose. So it mostly gets trained on data sources, either coming from the care providers, from the electronic health records, from the insurance claims, from even patient wearables or like some information from the FDA as an example, and also from the publications and our knowledge bases. And it should cover multiple modalities. And what I focus on is mainly the tables and text, and mainly the tables on our structured EHR data, which is like very huge, very large. We have already access to millions and millions of records. So Med-BERT, which is the first early version, is actually trained on structured clinical data, and it was trained on more than 20 million patients from the Cerner Health Facts dataset, which was a de-identified dataset that our school was an early adopter for this one, and I think we were working on this dataset in 2016 and 2017. And this data covering the whole patient trajectory for more than like 50 million patients, from where we selected like 28 million patients, 8 million we keep for testing purposes, and we trained only on the 20 million. And we use the BERT architecture, which is a bidirectional encoder, which means that it will learn from both directions, and it is an encoder only, as Dr. Jiang presented the transformer architecture at the beginning of the session. We focus on the encoder because we are more focused on learning the patient representation. So we used this architecture and it trained on two tasks. The first task is the self-supervised learning task, just mask one code in the patient trajectory and try to predict what is this code. And the other task is kind of a classification task that can learn from the whole patient trajectory, like from his past and his future as well. So we tested a number of outcome indicators like readmissions or prolonged hospitalization, and we found that the prolonged hospitalization worked well for us. So we use this task as another pre-training task. And then we tested our model on two prediction tasks. The first one is on patient risk to develop heart failure. We focus on diabetic patients. And the second one is the patient risk to develop pancreatic cancer. So in very simple words, we use a whole patient medical history. We trained the Med-BERT to get this patient representation. And on top of that, we added a small classifier or a small machine learning tool that is specific for the prediction task. So this is like, it might be complicated, but just like a technically illustrative diagram how it works. So we have the patient history in ICD codes, And then the model will learn those numbers. Those are what we call the representation or the embedding vectors. And this is what we feed to another classifier to give us the predicted score. So what we found out that Med-BERT was doing was extremely amazing because it helped people and hospitals with small local data to have like a models that can perform or outperform the models that they can train just on their data alone without the use of Med-BERT. So the blue line here is what you can see. That is the performance if you only have like 100 patients, 300 patients, 500 patients in your cohort, and you just train your model on these patients' data. But if you use the Med-BERT, your performance will be boosted from 55% to 75%, like as quickly as possible. And this gives you the same performance as if you have 3,000 patients. So it gives you a performance boost as if you have larger data, which might be hard to get. So that just in order to summarize, we just take the untrained Med-BERT or like the BERT architecture, we train it on more than 20 million patients. We have a pre-trained Med-BERT that we are using as a foundation of our another classifier, which is that small predictive model on top of it. I just fine-tuning the local data, which can be only 300 patients, and I get like the specialized model that can give me a 75% accuracy. Or you can see here also the same for the pancreatic cancer, it has more than 23% boost in the accuracy. So when we published that, we only use diagnosis code, ICD-9, ICD-10. We just use a Cerner Health Facts, which was having the patient data from like 2000 up to 2017. And we didn't get approval from Cerner at the time to share the model. To be honest, we didn't ask for that. So now we have access to more data at our school. And one of the latest data sources that we had access to, or we used to have access to, is the Optum Clinical Informatics, which was like a huge claims data set. And we extracted 50 million patient data or full trajectories from this claims dataset. And we used this one to train another version of Med-BERT. And also we included medications and procedures besides the diagnosis information. And for comparison purposes, we trained another version on the Cerner data just to compare how it will perform. And as we found out, like the original Med-BERT model on like the heart failure task can boost the performance by 3%, going up from 82 to 85. And for pancreatic cancer, go up from 76% to 82%. So you can see like there is a quite big jump in the performance just using the patient diagnosis information alone. No medications, no procedures, nothing. But then we added the procedures and the medications, and we see that we have like slightly better performance when we added those information and when we use the procedures and when we use the Med-BERT V2, which is also pre-trained on the procedures and the medications. Med-BERT V2 claims was a little bit showing slightly less performance, but still it achieved a big boost from just using the raw data alone. We also tested Med-BERT V2 on additional tasks that we might not be able to do for the original version of Med-BERT, such as the medication recommendation, where you can see that we can do we can predict the correct medication, either the category by 94% or the generic name by 91%. And we have here the results of the logistic regression just for baseline. Also, we tested another phenotyping algorithm. For those, we already used pre-existing datasets and phenotypes on the MIMIC3 dataset in order to just confirm the generalizability of our models. We completely train our models on Cerner or Optum, but when we evaluate, we test on some datasets from Proven, and here we are testing on datasets from MIMIC, so we are proving the generalizability of and the good performance of our model. And I give the credit for most of the results appear in this slide to Yanshu, who joined, who is working with us on these projects. So just like in summary, Med-BERT is publicly available now. The paper has more than 350 citations, and the GitHub repo have more than 200 stars, and actually many papers already used our code base to train their own foundation models, and like they applied some enhancement on top of that, and was amazing, and we actually learned from that. And many of those users already communicate with us during their process, and we are welcoming that all the time. Also, I'm happy to say that we are sharing now the model. We started the process, so you can feel free to fill this form. I'm not quite sure if you will have access to this slides. If you do have access, you can just use this link to request the access for the Med-BERT model. Otherwise, you can file an issue on the Med-BERT GitHub repo, and we will share the link with you. So we use this work, and actually recently we get funded for the same project, but just to grow it, because as you can see, whatever we have done, we believe it is limited, and the domain is running fast, and I see there are huge opportunities of it for improvement, especially with release of large language models and a lot of newer algorithms that are more accurate, and they can be even better to empower our clinical foundation models. So we are proposing, or we are actually working now on empowering our data, which we strengthen that with some knowledge base from ontology, as well as like changing in the architecture of the foundation model. BERT is pretty old. We are using newer ones now. And we also test and add some prompts to allow few-shot learning. We hope to come to the zero shot, but so far we found like if we do few-shot learning with just like 10, 20 sample, that will be good or perfect for our case. And we also test different downstream tasks, including patient similarity, which is another work that we are working on nowadays. So this is our clinical foundation model project that we are working on, and we are welcome any ideas or recommendations for collaboration. I'll be happy for that. So an additional resource, I think it might be of interest of the majority of you. If you want to develop or train your own deep learning model, we also have a GitHub repo that allow you to do that. It has some tutorial. There will be a tutorial under the name of the, you will have this link, and then you will have PyTorch EHR_3_clinician. If you have this branch, it will take you to a tutorial on how you can prepare your own data. And once you prepare your own data with that shape, you can train machine learning models and deep learning models as you like and compare with them. We have Dr. Masa Yukiniku, who already developed one of those models for the MRSA predictions. And actually, he presented his work in the ID Week last year, and he is, like, I think the paper is in a second minor revision phase in Nature Communication, which is good. We use the same thing for our COV-RNN paper, which was published in the Lancet Digital Health like 2 years ago. Okay, I think, and this is just like that. Point of it, it just use all patient trajectory until a certain point, and once we reach that point, you can see that is, you can do multiple prediction tasks, either binary or survival predictions, and you can see the good performance it can achieve. With that, I'd like to acknowledge the amazing group I have belonged to, and the whole school, and the amazing collaborators and co-investigators. Also the school data service team, and how far they are making many data sources and made available for us that we can work with. And for sure, our team members and the co-authors. With this, I thank you, and I'm open for questions.